Good morning, dear friends. Today we are going to discuss about myocardial infarction. Now, we are going to discuss about the classical presentation of MI. The first one is the chest pain. If the chest pain lasting for hours, then probably it is because of myocardial infarction. Second is the nature of the pain. The pain is sudden and very severe, or if you feel tightness in chest with restlessness, with perspiration or sweating or vomiting, then probably it is because of the myocardial infarction. As compared to angina, it is irreversible damage to the heart. Now, investigation for myocardial infarction. The ST segment is a little bit elevated when we see this ECG. Q wave is broadened and deep, and T wave tall, either inverted or upright. You see the difference between angina and myocardial infarction if you read it from ECG. In angina, ST segment is depressed, T wave inversion, tall or pointed upright, while in myocardial infarction, ST segment is elevated, Q wave is broadened or deep, and T wave is tall, inverted, and upright. So that is the difference between angina and myocardial infarction. Now see, what are the other non-specific tests? Number one, ESR above 70 millimeter in the first hour. This is the first important non-specific test. Then polymorphonuclear leukocytosis is there, that is 20 into 109 per liter. Cardiac enzymes is also changed within 48 hours of the infarction. Creatinine kinase increased up to 24 hours, then it will get normal after 48 hours. Within 3 days, you will see rise in aspartate aminotransferase, rise in LDH, rise up to 3 to 4 days and remains high up to 12 days, and troponin T and myoglobin rises. This is again high up to 7 days. Segment depression is there. Then aim for the management of myocardial infarction. Number one, oxygen 60% by face mask or nasal cannula. For the treatment of the pain or anxiety and apprehension, we will use diazepam, morphine 10 to 20 milligram intravenously or subcutaneously, yeah, diamorphine, that is 5 to 10 milligram IV or subcutaneously. Along with this, we can administer anti-emetic drug like cyclizine 50 milligram IV or metoclopramide, that is 10 milligram IV. Then correction of acidosis due to lactic acid production, we administered sodium bicarbonate by IV route. Then thrombolytic therapy, it is beneficial only if it will be provided within 24 hours of the settlement of this myocardial infarction, and that includes streptokinase or urokinase or L-tablase. Then in the next step, prevention and treatment of arrhythmias, and for this we prophylactically administered beta blockers. If it start immediately, it will also reduce infarct size. Continues it for 4 weeks, it will also prevent other complications like myocardial salvage. For tachyarrhythmia, lidocaine IV, and for bradycardia or blocked electrical pacing or atropine should be administered. Then for the management of the pump failure, we'll administer number one, furosemide. If pulmonary wedge pressure is more than 20 millimeter of mercury, vasodilators like glycerin trinitrate IV or SE inhibitors, captopril, inotropic agents like dopamine and dobutamine, rarely we can use digitalis. For the prevention of thrombus formation, heparin 5000 units subcutaneously 8 hourly. Low dose heparin reduces deep vein thromboembolism. For the prevention of remodeling, we administered uh, SE inhibitors, and this prevent cardiomyopathies, and in the future prevent complications like congestive cardiac failure. For the prevention and reduction in the risk factor, modification of the lifestyle. Then secondary prophylaxis, we start low dose aspirin 60 to 150 milligram per day. Like this, the principle of treatment for acute myocardial infarction. So before hospitalization, for the relief of the pain, zero point 0.4 milligram nitroglycerin sublingually every 5 minutes till pain subsides, maximum 3 times. Then IV morphine 1 milligram per minute, maximum 10 milligram, with IV metoclopramide 10 milligram, and oxygen. This is before hospitalization for the relief of the pain. For antiplatelet action, we administered aspirin 75 milligram to 150 milligram once daily. After hospitalization, absolute bed rest, specific treatment for hypertension, SE inhibitors for prevent remodeling, means ultimately for prevention of the cardiomyopathy, which ultimately reduces chances of development of congestive cardiac failure. IV beta blocker decreases and restrict infarct size and prevent complications. Anticoagulants, then thrombolytic therapy that should be within 12 to 24 hours of the onset of acute MI. Then treatment of the complications and general measures that include diet, exercise, relaxation, bowel care, sedation, etc. Now discharge and secondary prophylaxis. Number one, gradual increase in the physical activity, including yoga, walking, exercise therapy, etc. Low dose aspirin should be continued. SE inhibitors, beta blockers, and risk factor modifications means there must be evolution from alcohol, smoking, hypertension, diabetic mellitus, hyperlipidemia, and obesity should be taken care of. So this is about myocardial infarction. Thank you.